Okay, great. Good evening to everybody, and welcome to this event on diverse, equitable, inclusive innovation for a more secure malaria-free world, which is co-hosted by the government of Ghana, the government of Switzerland, and Medicines for Malaria Venture, MMV, which will offer an opportunity to discuss this important topic, but it's also an opportunity to celebrate the 25th years of MMV, Medicines for Malaria Venture. So my name is Silvia Ferrazzi. I'm the Senior Director for Global Advocacy in MMV, and my role here is to help the transition and taking us through the various parts of the program and also doing a little bit of the housekeeping. So I will start with housekeeping, the usual request to switch off or put on mute your mobile phones, and I will do the same for mine, actually. And a reminder that the discussion will be in English, but if you prefer to listen or interact in other languages, the interpretation in French and Portuguese is also available, and there are some headsets in the back of the room. So we are privileged to have here distinguished representatives of governments, ministers, ambassadors, and other high-level delegates, leaders in global health organizations, and many partners around, and also many colleagues from MMV. And it's a pleasure for us. Why we have chosen this topic for our anniversary? Our hosts will have an opportunity to explain or to provide their own perspectives. In MMV, as you know, MMV is a non-for-profit product development partnership who works with its partners to discover, develop, and facilitate access to anti-malarials who are innovative, affordable, and accessible. And obviously, it is part of our core mandate as co-developers of medicines against malaria to contribute to address the market failures that indeed have a major impact on equitable and inclusive service to many populations affected by malaria, and exclude them actually from the possibility to enjoy the benefits of science. But also more explicitly, various aspects of diversity, equity, and inclusion are core part of our new strategy, 2024-2030, and you will hear more during this meeting. And organizing this event is for us a very good opportunity to learn going forward on how to integrate more and more these aspects in our work, particularly to understand what are the needs, what are the demands, what are the practices, good and bad practices, and also the policies in which our activities are embedded. And also offer an opportunity to share this sort of a lessons learning process with all the friends and partners that we have around in the world. And today here and this week here in Geneva for the World Health Assembly. So we would like to start this rich experience, and I would like to call to the stage for the opening remarks Ms. Erika Placella, who is head of the health section at the Swiss Agency for Development and Cooperation. Thank you.
Can you hear me? I'm sorry, I'm a bit sick, so my voice is... Can you hear me? So, okay. Thank you, and good evening, everyone, and thanks for the opportunity to be part of this event. So, we significantly invest in global health initiatives and recognizing the critical importance of addressing poverty-related diseases, including malaria. But beyond health, health is a priority theme as the SDC, which stands for the Swiss Agency for Development and Cooperation within the Federal Department of Foreign Affairs, The other teams also have as an entry point, as a focus, equity. So we also speak about equitable access to nutritious food and sustainable food. And the same for education, and the same for migration, and etc. So equity is really at the core of our action. And this is not, I mean, I remember I was just telling my colleague, I mean, 6 years ago, speaking about equity, everyone was saying, but it's a moral posture. No, it's not a moral posture, it's more than that. It's a moral posture, but it's also a case for investment. So it's both. So it's not just about moral endeavor. So, and the SDC, at SDC we found various research and development initiatives aiming at discovering new drugs, vaccines, and diagnostic tools for diseases prevalent in LMICs. Actually, our mandate is on LMICs. And of course, this includes PDPs, product development partnerships, such as MMV, but also DNDI. I don't see our DNDI colleagues here. Are they? Okay. So GODP, FIND, IVCC, and TDR. So Swiss-founded projects have made significant strides in malaria research, such as developing new anti-malarial drugs and enhancing vector control methods. Of course, this is complemented by specific actions at the country level. But this R&D part, this global part, is very important because it enables, really, it materializes a systemic approach. So the PDPs, they often collaborate with international organizations, including MMV, ensuring that the latest scientific advancements reach those in need. So again, the focus on underserved populations. So Switzerland prioritizes ensuring equitable access to R&D products. This includes initiatives to reduce the cost of essential medicines, of course, improve health infrastructure, and strengthen the regulatory systems, again, in underserved regions and settings. So as I said, we are committed to diversity, equity, and inclusion into the core of our R&D policies. This, of course, involves fostering an inclusive environment where researchers from diverse backgrounds can contribute to and benefit from scientific advancements. Swiss policies, and this is really beyond SDC at the department level, encourage the inclusion of diverse populations in clinical trials and research studies. And this approach ensures that research findings are broadly applicable and that all demographic groups benefit from medical advancement. So again, a broader scope in reaching underserved populations. So our policies also include that health innovations are accessible to all, particularly, as I said, in underserved communities. This includes the development of affordable and safe treatments and healthcare solutions, which are tailored to the needs of diverse populations. So the Swiss-supported initiatives specifically target vulnerable groups such as children and pregnant women. This includes research, for example, on pediatric and maternal health programs that aim to reduce rates and improve health outcomes for these populations. Maybe some of you remember that, colleagues from MMV, maybe you remember that in the past we supported the pregnancy registry to provide anti-malarial treatment options for pregnant women and empower them and their health practitioners with informed decision-making. So this was in addition to the core contribution, so targeted contribution for the pregnancy registry. So what do we envision? We envision a global health ecosystem where diverse, equitable, and inclusive principles are integral to R&D activities. This means creating research environments that include diverse perspectives and ensuring that healthcare innovations are accessible to all, regardless of socioeconomic status or geographic location, the famous determinants of health. So to achieve this vision, Switzerland advocates for several policies changes. I'm just going to mention 3 of them here, the most important. First of all, allocating more resources to research projects that focus on diversity, equity, and inclusion, and address the health needs of underserved populations. Secondly, encouraging the development of local manufacturing capacities in LMICs to produce essential medicines and healthcare products, locally, reducing dependency on external sources and improving access. And thirdly, involving local community in the planning and implementation of health interventions to ensure that they are culturally appropriate and effectively addressing local needs, or the famous localization, which is a new buzzword in our community, as most of you most probably know. So in conclusion, we need, in order to achieve, greater diversity, inclusion, and equity and inclusion, we need greater global collaboration in promoting diversity, equity, and inclusion in R&D. Of course, it requires effort to create a collective effort to create a more equitable health system that can respond effectively to the health challenges faced by underserved population. But this is not only for R&D. If we are not able, to be there with a bold response on the other, aspect of access, then we will not make it. So it's very important to have a comprehensive approach. Equity cannot only be reached when it comes to R&D. It has to be, health systems have to be inclusive, they have to be equitable, they have to be sensitive to key determinants such as gender, for example. And so it's very important to have a very comprehensive approach to equity. It's not just about research, about clinical trials, it's about services, and it's about communities. And it's really beyond, I would like to insist on that. It's not a moral posture. Equity, inequity costs a lot. There are a lot of studies. You can have a look at those studies. It's very expensive to be inequitable, including in Switzerland. So last year we carried out, Blaise, I'm sure you know about this. There is a study showing, how much it costs having people showing up at the emergency in Lausanne, just because they don't understand the language, the leaflet. They don't understand why they should come for. So inequity is very expensive. So that's I think it's a very good case for investment, really to remind people it's not just about moral, having a moral posture. It's really about, and it's also a question of, being equitable is to be more efficacious, more effective when it comes to the control of transboundary diseases. So these are, for me, equity is a multi, it encapsulates a lot of other concepts, and it's really a combination of moral posture, but also of cost of not being equitable. From the research to the jab. Thank you.
Thank you, Ms. Placella. And it is a privilege for us actually to be a PDP hosted in Switzerland because of this alignment actually, and this similar investment in poverty-related diseases, but also on research, but with this additional point that you made, which is very important, that R&D operates in an ecosystem which is much broader and that needs support. So I think we are ready for the first panel at this point, certainly. And I would like now to invite the distinguished speakers of the first segment, which is called a leadership segment, driving diversity, equity, and inclusion in innovation for global health, and will look actually at the political funding commitments and decision-making around these topics. I would like to, first of all, invite to sit on the stage the moderator, Dr. Ms. Joy Phumaphi, former Minister of Health in Botswana, currently Executive Secretary of the African Leaders Malaria Alliance and Chair of the RBM, of the board of the RBM Partnership to End Malaria, and also member of our board in MMV. And the other distinguished speakers, His Excellency Dr. Bernard Okoe-Boye, Minister of Health of the Republic of Ghana, who is co-hosting this event. Thank you for being with us, Dr. Boye. Dr. Philippe Duneton, Executive Director of Unitaid, and Dr. Ngashi Ngongo, Chief of Staff and Head of the Executive Office of the Africa Centers for Disease Control and Prevention.
Hey, ça va?
Ms. Phumaphi.
Bonjour, ça va?
Thank you. Welcome, everybody, honorable ministers, distinguished guests and partners, friends, and advocates in our fight to save every child that is dying every minute from malaria. We're losing a child every single minute to malaria. So I welcome you to this event because malaria is preventable first, and it is treatable. So where is it that we are missing the equity? Where is it that we are missing the inclusion? Where is it that we are missing the diversity that will enable us to save every single child? We have this distinguished panel which is going to help us answer these important questions. So I will start with you, Honorable Minister. So, Honorable Minister, your government is known for mainstreaming diversity, equity, inclusion into its national programs. But how are you doing it in public health? How are you ensuring that we do our best to save these children that are dying every minute? Minister.
First of all, let me thank you very much for having me on this panel. And let me thank all who are here to ensure that there's equity when it comes to the delivery of healthcare. Well, first of all, let me say that even from the constitutional level in our country, we are supposed to be non-discriminatory towards sexes in the delivery of healthcare, education, and all other social services. In Ghana, we obviously, anyone who is in the health sector can mention some particular conditions that are biased towards either particular sexes or people in a particular economic class. So, for example, chronic anemia is sort of prevalent in girls of school-going age because of the menstruation that happens in girls and not guys. And so, as part of the ministry's program, we have programs that allows the health system to go out there and give folic acid tablets, especially to the girls, to make sure that their blood level is usually correct. The biggest cause of inequity, most of the time, if not all the time, in the population, are those who are in the remote section or in the lower economic levels. So when you come to the cities, hardly would you find anyone dying of malaria, children under 5. But it is not much news when you go to the very remote area where a mother would have a child with fever, with high body temperature, and because of a combination of either financial constraints or ignorance, would use certain herbal or other concoctions to try and save the situation, and would rush to the hospital only when the child is becoming unconscious or cannot feed. And so, because we know that these are the factors that result in mortality in children from malaria, the government has taken it very seriously to have health units, what we call health centers. In fact, we have devolved it down to CHIPS compounds, which is a basic health facility with an experienced nurse who makes sure that they have a list of all, especially nursing mothers, women with children in the community, and they visit them. So that if a child is not well, but the parent is not bringing the child, the nurse is able to pick the child from the house and give the intervention. I think at this stage, it is quite, it's supposed to be common information that access to the medicines is not really a challenge. It is knowledge from the population to come for treatment when they have malaria. And for prevention, maybe, I don't know whether we'll have a section to talk about it, but there's a lot of work being done when it comes to spraying in communities, residual spraying. There's a lot of work when it comes to giving out of mosquito nets and all that. But in terms of treatment and ensuring equity, we are working very hard to reach those remote areas where a combination of poverty and ignorance makes children die unnecessarily from malaria. Thank you very much.
Thank you, Honorable Minister. So you have covered sort of the inclusion, the equity, the diversity, bringing the women, to the treatment and taking the treatment to the women. Because like a lot of poverty-related diseases, malaria has got a female face. It has a female face. Now, you have talked about the country-level approach. Now, let's talk about the international approach at global level. Philippe, what has been your experience? What are the mechanisms that you have used to address this inequity, this need for inclusion? How do you make sure that at global level, we are actually reaching the last mile in communities?
First, thanks, Joy, for the question, and thanks, MMV, for first the 25 years anniversary and its new strategy. I think it's an important step. From our point of view and my point of view, I think that we are doing 3 mistakes all the time in public health. The first one is not to take sufficient attention to innovation. It's always seen as a problem, more expensive, more complicated. The second issue we face is that we don't listen to people because we are medical doctor, we are professional health care, and we should know. And I think that we are the last sector of activities where what we call user experience, customer experience, is not factoring. So and the third is that to consider, sorry to be a little bit graphic, but poor people are stupid. And a lot of times we went through situations where, no, but the people will not understand. It has started with the access to antivirals, and African doesn't have a clock, doesn't have water. But I have a ton of examples, unfortunately, and I think that even the thinking is inequitable. And I think that what we want to, and we try to address that proactively. Thinking about innovation is not just the product, is how the people themselves will have access to. And not only the professional plus the people. And we have seen, for example, we have a lot of intervention, for example, for preventing malaria among pregnant women. Not so easy, but quite absolutely key. It was a community-based intervention. During the COVID-19, to be honest, it was more resilient than most of the governmental program. So looking at innovation in that, we have, for example, invested in self-test for HIV and for HCV. Again, is to decentralize, in a way democratize, but closer to the people. And I think it's one of the key maybe figure or way to think to respond to inequity, to respond to real impact, because at the end of the day, what matters is not if the product is working, is, of course, what does it change for the life of the people. And we have invested, for example, a lot in pediatric formulation. And believe me, when we start Unitaid, there was no pediatric formulation for the new ACTs. There was no pediatric formulation for TB. There was no pediatric formulation for HIV. And we invested, and now we get it. But it's not because we like the children. It's because the children, when they don't have access to the right formulation, they die. That's it. That's, for me, very concrete example. But the same for pregnant women, you know. A lot of drugs, not to malaria, but for example, HIV has been developed with a male population. And of course, when you use it in Africa, you have to use it among children, you have to use it with women, you have to use it with pregnant women. So you need to include this population to sometimes do the clinical trials that has not been done. And I think it's a way to be more equitable and inclusive. So I think it's for me and for the organization, and the organization is not just Unitaid. I just want to say that Unitaid is about the people, is about the product, of course, and the way you use it, but about the partnership also. We don't do things alone. Partnership means partners like MMV and others, but also countries. And so with that kind of values or good practice, that's the way we engage and think about innovation.
Thank you so much, Philippe. So it is about the community, it is about the woman in the community, it is about her voice. In fact, the majority of the women whose children are dying from malaria are young women in their teens, in their 20s and early 30s. And these are the people who are now saying to us, nothing for us without us. And so this is where you start. These are the people who have information on what they want, what they need, and how it should be delivered to them. Now, this is a huge challenge. Dr. Ngashi, this is a huge challenge because it means even the R&D has to be structured in such a way that it is driven from the community. The manufacturing has to be where the people are. So you are running with your bosses an intergovernmental organization for a large continent. How do you ensure that we observe these principles of equity and inclusivity in our approach to R&D and manufacturing?
Yes, thank you very much, Joy. And first of all, congratulations to MMV for the 25th anniversary, very important. I think to look at the contribution that this organization has made to the needs of the most vulnerable, especially to the needs of people like us who come from Africa. And secondly, I also would like to present the apologies of the Director General, who really wanted to be here, but because of, as you understand, so many pressing commitments, he couldn't make it. Then we are here to represent him. Now, just coming back to your very important question, is that we remember that every time that we talk about access, we look at access, first of all, from the angle of the financing, from the angle of the price, from the angle of the systems. But COVID taught us another lesson, that access is also determined by who is producing and where they are producing. Even if you have the money, you might have your money, but you still don't have access. That is why manufacturing for us in Africa has become a top priority, because it's important to ensure the access for those women and children that are always the most vulnerable. Now, what are the current challenges? I think we have one major challenge, if I can start, is the issue of capacity. Capacity for R&D, capacity for manufacturing. You know that most of the product that we get, if you just look at the current production in Africa, less than 10% of vaccines that are produced in Africa, less than 5% of diagnostics produced in Africa, less than 30% of therapeutics produced in Africa. The reason we don't have the capacity to produce. But we have to say that some good news is that we've been doing the landscape analysis to see what capacity do we have on the continent. On vaccines, we have at least 3 manufacturing facilities that are ready to produce in the next 3 to 5 years. On malaria commodities, which we are talking about here, we've done an excellent work with MMV, and I've identified about 6 manufacturers in Africa that are ready to produce the vaccine drugs on the African continent. I think capacity is number one. And then number two is the whole issue of financing, which I'm also linking to, again, what I've said. The 6 manufacturers that we found in Africa, right now, they have expressed the need, about 15 million, I think, that has to be given to help them build the capacity to get them to go through the entire process, strengthen the infrastructure, have the pre-qualification and so on from WHO to be able to produce. That whole issue of financing has remained an issue. You are aware that on vaccination, we're now working with Gavi to get the AVMA with the $1 billion that is put to really support the manufacturers on the continent. It is the same effort we are also doing on malaria, again, with MMV, to ensure that we can really mobilize the needed funding for us to then get those manufacturers, including even for API, I think, because one of the things that we are pushing is that the manufacturing, we really need to have the end-to-end process conducted in Africa. Now, one golden opportunity now that we have in Nigeria, a company that can produce even the active pharmaceutical ingredient. But all that is now waiting for our financing to make sure that we can address that important bottleneck related to financing. And another very important challenge, again, is the issue of regulation that I think many of you are aware of. Right now, the EU has made an effort to produce this African Medicines Agency. That it's a way to see really the goodwill of a continent that is waking up to try and create the systems that can really facilitate the manufacturing, because you can produce, but at the end of it, those products have to be used at country level. They are not going to use if they don't go through the regulatory process. Now, what we're trying to do is to have AMA as one single continental agency that can register product then to be used in the 55 member states. Because that is taking time, we are now working on strengthening the capacity of the national regulatory agencies to be able to take that role now while we are building that continental thing. That to say that we are on that track that we are really working very hard to make sure that we bring R&D to Africa, to make sure that we also bring manufacturing to Africa, and we are very grateful, I think, for the work that is now being done with our key partners, including MMV. That's why it was with great pleasure that we are coming here, because we know that this is an organization that we need to succeed, because its success is also the success of Africa.
Thank you so much. Now, we do have some honorable ministers here. I don't know whether there's any minister who would like to ask the panel a question or make a comment. Honorable Minister Togo, any honorable minister who would like to speak or make a comment? If we feel that all the issues have been covered, I would like to take us back to the panel just for... Yes, Honorable Minister, would you like to say something? The mic is next to you. Okay.
Thank you so much to the panelists for these insightful thoughts and ideas. In my country, we are very close to control malaria, but one question that I will have for any of you is sometimes is the behavioral component for communities. What I'm trying to ask with that, sometimes people think that what they are feeling is just normal. And when you are trying to push to the last mile, is probably when you have the hardest task. What kind of recommendations or thoughts you will have for that last mile efforts?
Thank you, Minister.
Control and eliminate malaria one day.
Thank you so much, Minister. Very important question, and extremely important regardless of the endemicity. So, Honorable Minister.
I think before I come to this question, let me say that the treatment net, any program that targets treatment to the last mile might miss some of its targets, but the vaccination net is quite effective. And I believe that those here, we are aware that a malaria vaccine has been worked on, and a few kids have started to receive this malaria vaccine. Any disease that is prominent amongst children, once a vaccine is developed, over time, medicines for treatment goes down or phases out whilst vaccination takes over. And I believe that one of the smartest ways to deal with inequity right at the foundation is to make sure that we improve on this vaccine, and as much as possible, every country where malaria is endemic, kids receive these vaccines for two reasons, which I believe we all know. If you have a vaccine and you even get the condition, the clinical presentation is likely to be less, and we are likely to avoid mortalities. So that is one area that I would mention. One of my professors in school has been on this research team that developed the vaccine over the years. Now, for the last mile, I think a registry of all children born in community, and let's be blunt, the higher the education or economic class of a parent, the less likely that their kids will die from malaria. In fact, any woman, and I support you when you say malaria, the face is woman. Once the woman is educated beyond basic high school or tertiary, they would usually present to a health facility with symptoms. Those who don't believe their children are sick and all that usually are in the class where education is not strong. But if you have a registry of all kids born in even a village, then visitations to the kids would be able to help you pick a child who has symptoms but is still being kept in the house. And I keep on mentioning kids because malaria kills mostly in children under 5 because the blood-brain barrier is not well established. So you would always have some children who would not come to the facility, but an aggressive registry would make you know that you have kids. And community health workers, you need to have nurses and volunteers who would check on these kids. And they are the best people to pick danger signs for you. And it's one of the things we are doing in Ghana, where nurses visit homes and they know the parents. And sometimes they even call the nurse if a child has an issue. It's the moving, transporting yourself to the clinic is also sometimes an obstacle. So when parents can reach out, and in Africa, I think now we have more mobile phones than the population. So any program which allows the patient to talk to the provider via phone makes life easy. And parents are able to call a nurse and say that your child is not too well, and the nurses visit and make sure that the child is taken care of. So I think that registry must be strong.
Thank you, Minister. Very, very important points.
Okay.
I would like to go to Philippe and ask you, what are the implications here for, in terms of reaching the last mile for R&D, and also for the medicines, the type of medicines that are produced? How do we actually facilitate reaching the last mile at country level, at that level?
I have to say that the minister was very eloquent. In a way, the population is a problem, but is also the solution. And I think that in terms of innovation, people, when they understand, and in particular women, and of course, the efficacy of the uptake is linked with women. We have, for example, invest a lot in seasonal chemoprophylaxis of malaria in the Sahel, starting with 5 countries. It was a recommendation for 5 years by WHO. Nobody cared. And we did that with Malaria Consortium. It was not easy. But when we started, it was 13,000 children who have access to that. Last year, in the WHO report, it was 54 million of kids. Well, in 10 years, but it's a dramatic change. And the driving force was the mother, because the mother, they saw that their kid was not sick during the rainy season. They were not sick. In fact, it has created a problem in certain countries because they have to close down the dispensary, you know. But at the end of the day, it makes a huge difference. And of course, national program picked up, and with the support of the Global Fund, PMI, but also with domestic fund. But all the dynamic were coming from the mother and the woman in the country. So I think we have other examples, but I think that the people can drive the change.
Thank you. Dr. Ngashi.
Yes, thank you very much. I think just to add on what Philippe was just saying, that you get the right tools, you get the most efficacious interventions. At the end of it, you need two things. You need a system that can get those tools to the last mile. Now, a system is first of all the logistic of just transporting that. And you know the reality of those deprived communities that there is no infrastructure, there's no road, there's nothing. I think that's one first challenge, is that how do you get your product there? The second thing is you need the people that can deliver, then administer. You know, there are countries where you have 40% of the population resides beyond 5 kilometers of a health facility. That's why it is striking. That's why you've heard now this push that we are pushing toward the 2 million community health workers. And one thing that's also unique and very important for the discussion we are having is that 75% of those community health workers in Africa now are women, and young women. And the push now is that if we can get really young women between 20 and 35 years, we're empowering them, not only that we have an economic return to them, but it's also the skills that transforms this new cadre of young mothers that can be themselves the educators of other mothers in the community. Now, that's why we are pushing that if we do that, then we have in places where there's no health facility at all, at least there's a young woman that can deliver these interventions. But then one thing that we are also doing is that sometimes we use a medical kind of approach to the delivery of these interventions, forgetting that we also need to understand the social, anthropological context of administering these interventions. I think that's what we are also bringing into our program to make sure that there's nothing that we can achieve that last mile for the community without the community themselves also contributing to the best way that we can deliver them services. That's what we are combining, that understanding, but also using these young women to be the ones that are driving the agenda. We'll be able then to reach the maximum number of people, you know, in those remote areas, the last mile.
Thank you, Dr. Ngashi, and thanks to our team of experts. So you need to listen to communities. Again, you know, all of you the same thing. Listen to communities. If that young mother, the young community health worker says the rectal artesunate is the easiest to deliver, then that should be what is delivered. And I would like to thank MMV for making that available for our babies. Honorable Minister, you have a question.
Merci, je m'exprime en français. Et merci de nous avoir invités à cette rencontre d'échange. Je voudrais poser une question à mon collègue du Ghana.
Can you just wait, Honorable Minister? Do you understand French? Should we give you a mic? Can we have that? Sorry. Okay, thank you. Honorable Minister.
C'est bon?
Un minute, Monsieur le Ministre. C'est bon.
C'est bon?
C'est bon.
Oui. Alors, depuis un certain temps, on commence par parler du vaccin contre le paludisme. Et on sait qu'il y a une certaine efficacité. Ça commence par être un des moyens utilisés à côté de la prévention par les moustiquaires, à côté des médicaments. Et avec Gavi, le Cameroun a déjà commencé la vaccination. Le Togo, c'est dans les mois qui viennent. Entre-temps, on a appris que le Ghana est en train de fabriquer un vaccin. Alors, il n'est pas encore homologué. Je voudrais savoir où ça en est. Parce que pour le moment, les vaccins qu'on utilise sont des vaccins fabriqués en dehors de l'Afrique. C'est la première question. La deuxième question, c'est à propos de MMV. Est-ce que les produits qui proviennent de MMV viennent d'Afrique ou bien ça vient aussi d'autres pays en dehors de l'Afrique? Parce que quelle valeur ajoutée avons-nous avec les produits venant de MMV par rapport aux autres produits qui nous viennent d'ailleurs? Merci.
Thank you, Honorable Minister. So you understand the question, Honorable Minister?
Yes, I do.
Yes.
Let me thank him for the question and to say that it's not only with the malaria vaccine. He wants to know whether Ghana is producing the vaccine and the fact that the ones being used now are coming outside the continent. Since we are talking about inequities, I think one of the best ways to address inequity is to help transfer technology to places where the medicines are needed most. And so if medicines are being given to the African population for, let's say, malaria, but only 5–10% can be produced in Africa, that in itself, it's a fundamental problem. And so from this forum, I believe we would all be inspired to work towards technology transfer. I think what happened with COVID was a classic example. When you take India, where India had the AstraZeneca vaccines because they had the capacity to produce the vaccines, although it had been developed in the UK. And it was not only available, but it also affected pricing. And we have learned that in Ghana, most of the medicines that we now produce in Ghana, the prices drop compared to when it was imported, and the availability improves. And so I wouldn't like to go into the origin of the vaccine. All I know is that the malaria vaccine is being administered in Ghana, and what I want to encourage is that the partners, we should all come together so that we'll use malaria vaccine as the first vaccine that is produced predominantly in where it is meant to treat diseases. That is the point. And R&D, I think most of African countries, because we have some challenges to deal with, investing into research and development sounds like a luxury because you have pertinent issues. But over time, maybe we have to work with our development partners so that when some support comes, some should be tagged R&D, so that at least there is some compulsion into going into R&D. And finally, when you come to Ghana, you cannot have a vaccine manufacturing base without having a regulatory body that would give the certification for the level of biosafety to produce the vaccines. And so government, together with partners, is supporting our Food and Drugs Authority to get to the level, I think level 4 or 5, where you have the capacity to actually inspect and then give approval for the safety levels of a vaccine. I think when we invest in all this chain, we would be able to address inequities. I thank you very much.
Thank you, Honorable Minister. And for my colleagues who don't understand French, one comment that the Honorable Minister made before he asked Ghana about the manufacturing of the vaccine, because, you know, we're all excited when we heard that Ghana wants to manufacture the vaccine. We said, okay, technology transfer to the African continent. And we are looking forward to that, Honorable Minister. But the one comment that the Honorable Minister made is that the vaccine has to be introduced together, used together with other prevention measures like mosquito nets. And I think that's a very important, reminder. And I thank you, Honorable Minister, that because it has low efficacy or medium level efficacy, it is best to not to throw away any of the other preventative mechanisms, whether it is use of nets, IRS, all the other preventive mechanisms that we have, but use them together. We thank you for reminding us of that, Honorable Minister. I think we are running over time, and I want to thank our distinguished panelists, and let us give them a hand. And now that MMV is the same age as the women it is serving, I think let us congratulate MMV for appreciating that these women need to be treated equitably, they need to be included in the R&D and the decision making, and they are diverse. It's not just one type of women, but a diverse group all over the continent who have to be reached through the last mile. Thank you so much.
Okay.
Thank you, thank you.
Thank you very much indeed. So first of all, I would like to check if the online speakers are connected at this point. Yes? Okay, great. Okay, so now we will try to go a little bit more in depth into looking at the needs and demands and how research and manufacturing capacity and practices are aligned and what recommendations we have, again, for the decision makers. So I would introduce, first of all, the moderator, Professor John Reeder, Director of the Special Program for Research and Training in Tropical Diseases, which is a UNDP, UNICEF, World Bank, WHO initiative. Please, you can take your seat. And also Director of the Department of Research for Health in the Science Division of WHO. And also the speakers that we will have on the stage, Dr. Marcus Lacerda, Director of Research at the Foundation of Tropical Medicine in Manaus, Brazil. Ms. Olubunmi, Bunmi, Lawal, a pediatric nurse and also former president of the National Association of Nigeria Pediatric Nurses, and representing here also women in global health. And Ms. Andrea Lucard, our Chief Officer for Corporate Strategy and Affairs in MMV. Online, we have Mr. Shreehari Acharya, Program Officer in the CSO, Civil Society Platform, ALIGHT Southeast Asia, based in Thailand. And thank you particularly for being here with us at a very late time of your day. And Fredros Okumu, who I don't see on the screen, but maybe it's just myself. Fredros Okumu, who is a research scientist at the Ifakara Health Institute in Tanzania, and also professor of vector biology at the University of Glasgow. Welcome, Professor Okumu. Turn over to you, Professor Reeder.
Thank you, and thanks to MMV for this very kind invitation for me to chair this really exciting panel. And of course, happy birthday. I was saying a little earlier, tomorrow TDO is celebrating its 50th birthday, and I'd hoped, it was my 50th birthday, but sadly long gone. I'm not sure I'd go back to 25 again. It was a little harder then, but it's great to see MMV getting to this point and doing fantastic work for the 25 years. This is a great panel because we have a mixture here between some frontline voices from medical activists and research side, really looking at what the current limitations on access and what inequity really means on the ground. And then we're complementing that with voices from research and manufacturing and really trying to look at how the R&D ecosystem can ensure access and equity and DEI. So what else can be done? What else could be done? What's the situation today? So these are the questions we'll be asking here. I'll try and pick up a little bit of time because I know that the most important thing for a chair is nobody should be late going to the bar. So I'll concentrate quite hard on this, but I think we still have some good time to do this. Once we've spoken with the panelists, there'll be a little time afterwards for you to ask questions. So start thinking them as you go along. We'll be very happy to hear your input. So maybe we could start online with Shree. Could we get Shree on the screen? And I'll be asking this question to all of our frontline. It's really, what does inequity and exclusion look like in your daily work with underserved populations? And what would your top 3 recommendations be for us to better address this as we go along? And it would be really great for people also if you could tell us a little bit about your program. I know you're at the ALIGHT program in Southeast Asia. It'd be really interesting to hear some of the background of where you're coming from with these comments. Shree, the floor is yours.
Thank you so much, John, for question, and let me thank MMB for making me part of this 25th anniversary celebration with this great discussion. So I'm Shreehari Acharya, working with CSO platform, which is a network of 60 plus community-based organization and NGO and representing communities in the Mekong region. And our work actually deeply connected with the topic we are discussing today, as we focus on equity, inclusiveness, and a right to health. So maybe I can start sharing my recent experience just to respond on what inequity and exclusion looks like. I was recently visiting just last week in Lao, one of the very remote ethnic community, which is 10 kilometers away from the paved road, crossing through bamboo bridge up and down and very tough road. It was raining that day when we traveled, and then we were just navigating small streams, lots of mud, very difficult road, just trying to give you the scenario, a real scenario. And we get to the village, the ethnic village, indigenous community live there, 37 households. It has no electricity, no internet, no telephone signal, and no safe drinking water. And on the day we visited, we found pregnant women infected by falciparum, and one 8-month baby had her 3rd PB infection, and they were on medication. And the babies who had 3 infections, she had first infection when she was 4 months old. So only clinical health services the village get at the village level is malaria RDT test and treatment, that's all. And all the PB gets medicine in the community, but they are referred to a health center for the G6PD testing, which is nearly 30 kilometers far from this very remote village. And these two, the pregnant mother and 8-month-old, they couldn't get treatment in the community because of their condition and their age, so they have to go to the health center. And I had a chance to talk to this 8-month-old baby's parent, her mother, and she shared her experience when her baby had 2nd infection. She has very high fever at midnight, and whole their 5 family members, they have to sit on a motorbike and then go to the health center for treatment. And then she said that she ended up treating her baby in a clinic, private clinic, rather than going to the health center, because the first treatment she had in the health center, so she think that health center didn't provide good treatment. So she decided to go to the private clinic, and she spent a week in that clinic, but no proper treatment. And the reason, because the baby was not
tratamento próprio.
So to me, this is an example of what inequity is. Some are getting services in their doorsteps and most are kept far away. And then what I just share as a story, this is the experience I had last week, is a typical of what I have seen and what I heard from our partner in the network in Mekong region. So I will stop here and then maybe I will come back with other response. Thank you so much.
Thanks, Shree. A really great start with a really solid real-life example. We seem to be picking up the football results or something, which could be really interesting, but possibly we should just make sure we've got that under control. We okay? Okay, great. Well, maybe we'll bounce off that, Shree, and move over first to Marcus, coming from Brazil. Does that story have any resonance with you? What are you seeing, and what are your thoughts about how we can respond better to the lack of access, lack of diversity, equity, and inclusion?
Well, I think that when we deal with anti-malarials and talking about equality, we have to understand that countries, they're not equal. So it's not supposed to have anti-malaria being equal to the whole population when nothing is equal in the country. In a country of our size, 10% of the population, they live in the Amazon, which represents half of the country. And 90% of the population, they live outside the Amazon. They have no malaria at all, but they have the institutions who have to deal with the implementation of drugs in an area where 10% of the population live and they suffer from malaria. Those communities, they don't know exactly if there is any innovation available. They're just waiting for those in the half of the country to approve drugs, vaccines, and whatever diagnostic tests that will go to the field. I think that there is something that we haven't been discussing properly, which is bureaucracy. People used to say that in Brazil we are very bureaucratic, so we admit that it's not our fault, it's the Portuguese fault. And the Portuguese, they blame the French where the word comes, bureaucracy. So I'm not quite sure where bureaucracy comes, but in Brazil, the tropical bureaucracy evolved a lot, and there's actually a lot of actors who are playing, trying to approve innovation and getting the innovation to the field. But there is no maestro, there's no one who's actually trying to tell people what they have to do in an organized way. So there are many institutions, and as we have here interpreters from Spanish to French to Portuguese, I think that one key thing to have when you're dealing with innovation is to hire translators from one institution to the other, because they don't know exactly what they're asking for. They blame the other institutions, so it's never their fault why the innovation hasn't reached the field. And sometimes you have to use some traffic of influence, which I use for the good. For the benefit of being a physician is that some people call me sometimes when they are aware of new drugs or new treatments. So when this new drug for Vivax malaria, tafenoquine, was approved by our equivalent to the American FDA, which is Anvisa, there was a lot of noise in the press. So everybody wanted to know when the drug would be in the field. So the first people who contacted me were not the people in the field, but the sons and friends of senators, congressmen, and people related to the president of the republic. So one day someone had malaria because they've traveled to the Amazon, they become infected, and they were aware of this new drug, and they knew that I was involved in the development of the drug. So the Minister of Health gave me a call, and she says, we're looking forward to your advice on how to treat malaria, and I've told the president that there is this new drug that we are about to use in Brazil. I said, well, actually, you said it correctly. We are about to use, but we haven't started to use. So tell the president and tell everybody that the day that they give some signatures and some papers, the drug will be available not only for him, the family, the friends, but for the whole country. So this traffic of influence is still needed in our countries. We have to ask people for favors to give signatures on tons of papers, because actually there's no community of malaria people who are going after their rights like we have observed in the HIV community. A lot of people went to the doors of those politicians asking for antiretrovirus. But there's no one who's sick of malaria who wants to go after a politician asking for the new tools, for the innovation that we all know they're for the good, but they have to reach the field.
Thanks. A really interesting example of complexity. And I'm sorry, Philippe, it seems the French, it's their fault. Let's move quickly to our next speaker, Bunmi. Bunmi, I presume as you're representing kind of women in global health, you've got a very much a perspective on inequity and women. Please.
Thank you so much. I really want to appreciate the organizer for considering those of us in the front line and all the excellency in the house. I want to recognize my minister, from Ghana. You know, Ghana and Nigeria, they are our brother. We are big brother Africa, you know. That is on the lighter note. This is very important topic we are addressing here. But just to set the record straight, poor people are not stupid. I can tell you for free. Poor people are not stupid. They might be incapacitated. They might be in a condition whereby they can't help themselves. They can actually be in a condition where they cannot take decisions, but they are not stupid. I can tell you for free that African women respect our men and we wait for them to take decisions for us. But that does not mean we are stupid. Now, when we are talking about inequality and lack of inclusion, I hope you are still hearing me. Okay. Okay. So we are saying majority of the people that need the required services do not have access to it. We are talking about delay in seeking for care. We are saying delay in reaching the healthcare services. And again, sometimes when you get to the facility, delay in even receiving, you need to come to the antenatal section. Okay, so because I need help here. Shout for help. Okay. Hello. Okay, thank you. Thank you very much. Can you still hear me? Okay, so if you get to my antenatal care, antenatal clinic, I might just be 2 midwives on duty, but I'm going to attend to 200 women. 200 women. How can I do that? Again, we are looking at inequity, isn't it? But trust me, like my friend here said, the rich one will not come to primary health care center, isn't it? And trust me, if you ask my friend here to go to primary health care center to work, what will you say? Will you go there? He might, look at the way he's looking at me. So obviously, he might not get there. So how do we transfer? How do we ensure access to quality of care? Which does not really matter if you are black, you are poor, you are rich. How do we ensure that? In the face of conflicts, in the face of insurgency, in the face of poverty, in the face of even lack of immunization. Now, you can't segregate it. Poverty, malnutrition, zero dose, most of our children who have no access to immunization, all of that put together dovetail and contribute significantly to when we talked about inequality, because we don't have equal access as you, Mr. Minister, has. Mr. Minister, you can just call him. He will pick. But trust me, sometimes I'm sure if you receive my call, you say, who is this nurse? Okay. Again, when policy, I love when the minister talked about policy. Policy is good. But on the table of the policy, who are there? Those who will tell you the true story. Those who will tell you what it is are not on the table. That is what we are saying. And what we are saying is the gatekeeper, the community leaders, the traditional leaders need to be on the table. If you don't have them, if you don't have the men inclusion, we are going nowhere. Because in the place like where I come from, in Afro region, we really listen to our men, even at the point of death. But how do you transfer all the technology, all the innovation, and ensure that it's accessible to the poor woman at that community? That is what inequality means to me. Thank you.
Thanks. And I guess from those first 3 comments, we see the complexity of the issue of access. It isn't a simple single question, but one of the things that's coming out here is that we need to be having this conversation at all levels. We need to be doing it politically. We need to be convincing people politically. We need to be talking with the gatekeepers into the community and moving down into this way. These are all elements. It will never be a simple fix into this, but we really need to understand what these issues are in order to build towards this. And that brings us very nicely to the second speakers who are coming rather more from the end-to-end research community. And really, the first question, and I'll start with you, Fredros, if I may. It's, one of the issues here as well is from the point of view of the research and manufacturing and the often lack of geographical diversity and the equitable distribution of capacities for this. What from your experience, are the needs for us to work towards a greater geographical equity in the R&D process?
Thank you, John. I hope you can hear me.
I hear you well, thank you.
Thank you so much. John, it's difficult to get to the answer to your question without acknowledging the excellent points raised by our three colleagues who have gone before us, Shreehari and Philippe and our colleague from Ghana. I think if we just took those three notes, that's already quite an advancement. The second point is really to congratulate MMV for the excellent work they have done so far since their establishment. And if the discussion is about equity and inclusion, I do not know if MMV team realizes it, but even if you just look at the portfolio of work that they do, they are focused on one hand on creating innovations for excluded groups, even like child formulations, the fact that they work on P-Vivax and P-Falciparum at the same time, the fact that they are working not just on drugs for cure, but also drugs for stopping transmission. This is really how, in a practical sense, we create this so-called inclusion. So congratulations on that. I mean, the WHO has informed us that there is probably 10 million malaria deaths that have been prevented since 2000. And I believe probably half of that, or maybe at least a third of that, rough numbers, of course, can be directly linked to the efforts by MMV and partners. So congratulations on that. To the question that you asked, Professor Rida here, about geographical representation, when I hear this all the time, and you see a lot of, in the previous panel, there was this conversation about manufacturing must be localized. But at the same time, when you speak to the manufacturers, they tell you about all the challenges that they have to go through to get the manufacturing facilities established in the country. And that simply means that this is a responsibility. I think there's some interference. What this means is that it's a responsibility for the private sector, but also for the countries to ensure that this manufacturing actually happens locally. The second point related to that is that I think there will need to be some justification, especially from our political colleagues, of whether this drive towards local manufacturing in Africa will actually mean that the medicines are more accessible than if they were manufactured in India. Because as evident now for many years, there are cases where it's still more difficult for people to move between African countries than it is for them to move between African and European countries. So we should not necessarily just assume that if Nigeria is now manufacturing medicines, that those medicines will be more readily available in Rwanda than if the medicines were being manufactured in India. Because at country level, these are still very sovereign states, if you like, and there's still quite a lot of difficulties or challenges to be addressed in terms of movement between African states. But all these are surmountable. And I think that with the economic blocks that are strengthening, with the regulatory agencies that are being improved. And our colleague Joy Pomfani is here, and she can talk more about this. With all these developments, it's possible and it's very likely that in the near future, local manufacturing will be a reality and a helpful thing. But even as we go towards that, we must address the truth, which is that there is not sufficient mobility between these African countries to guarantee movement of those products when they get manufactured. So we should be talking about access much more than that. But I want to stop there and listen to our other colleagues as to whether they have much better ideas towards making this a reality. Thank you so much, Professor.
Thank you, Fredros. Thank you. So finally, we move to Andrea and the perspective from MMV. So obviously, you know, in common with other PDPs, access is really at the heart of the whole development process here. But you've heard about the complexities on the ground. What can we do better in pushing R&D towards more equitable access and creating greater inclusion as we go through this process?
Thank you very much. First of all, thank you, John, for being willing to do this. And my sister in Women in Global Health, yeah, that's why I'm part of it too. This is an important work, and the Women in Global Health movement is a very important one in terms of supporting women workers around the world. Thank you all for being here and helping us celebrate our 25th anniversary, and in particular to think about this question about diversity, equity, and inclusion. We really have heard a lot about the challenges associated with access, but let me talk a little bit about the challenges associated with R&D and how we think about diversity, equity, and inclusion in the R&D process and why this matters. MMV, founded 25 years ago, was founded out of the crucible of vast antimicrobial resistance. That is the failure of anti-malarials to the people that needed them the most. This was devastating. It was a devastating period. And what the founders of MMV were able to do at the time is bring together the kind of partnership that we've continued, that is to say, with countries, with health ministers, with NMCPs, with the research institutions, and with the pharmaceutical companies to say, we're going to make access central to what we do. That is, we're going to make sure that anti-malarials are available, high quality, low cost, for the people who need the most, and particularly, and we began in the first product that we launched with Novartis, with children under the age of 5, a very underserved population. This morning I was talking to a colleague here at WHA around the problems of the pandemic treaty and what has happened or in fact not happened with the pandemic treaty. And his comment was, he's a pandemic expert, his comment was excellent. And I asked him if I could quote him, and he said, well, yeah, sure. And he said, equity is not something that happens. Equity has to be designed in. It has to be baked in. And it sounds quite obvious, right? It sounds like, well, yeah, sure. But from the point of view of what does equity look like, particularly in an R&D organization, what does equity baked in look like? Well, if you're talking about science, you're asking, and scientific inquiry, you're asking a question, you're making an observation, you're asking a question, you're developing a hypothesis, and you're testing that hypothesis, and then you're observing. So one of the things that we began to understand at MMV about why we were able to bring 15 medicines to market, why we have had a certain kind of success, has been in the increasing ability to ask the questions with our partners. That is, not MMV asking the questions, but what's the question that Fredros is asking? What are the questions that need to be solved and need to be understood at the front line of nursing so that we can start talking about what do these medicines look like? Along with the questions comes a certain degree of power, because the people who ask the questions are the people who get to design the experiments. So this is a very big part of what we began doing at MMV in looking at our new strategy. Now, I see that some of you are sitting on your strategy, so before you leave, make sure you're not sitting on your strategy anymore, on our strategy, but be sure that this is part of it. But what we know is that as an organization devoted to creating the products that can cure malaria, that can prevent malaria, and can eliminate malaria, we need to make sure diversity, equity, inclusion is baked in the question process. That is, who's doing the questioning? What are the questions? And then how are we developing the experiments to make sure that we're developing the medicines that have to be there? For example, the kind of work that our colleagues have been doing in pregnancy. We all know that malaria in pregnancy is a very serious disease, very serious condition. We also know that it's exceptionally difficult to deal with the issues of pregnant women in clinical trials. And for a long time, I think most of the world said, this is just too difficult. We just can't. It's too hard. And I have to, hats off to the courage of my largely women scientist colleagues, but not only, it's very important that that be said, that we started saying, well, we're charged by the world. We're charged by the donors. We're charged by the countries to solve difficult questions. Let's figure out how we're going to solve that problem. And let's make sure then we're asking those questions. We're asking the women in the villages. We're asking the ethicists who are sitting in the countries where we are. We're asking the newly nascent regulatory authorities in Ghana and elsewhere on how to do this. And we're making progress. So the second part of the diversity question is who's asking the question, and the third is where we're coming back on the African manufacturing and other things, which is where are the secondary benefits going to be? And this is not, as Erika was saying, this is not a moral issue. This is a sustainability issue. This is a very clear issue about how is this system going to work. We know that the world is not going to be able to provide infinite amounts of funds to Gavi or to the Global Fund forever. It's just not going to happen. So we need to be sure that we're building into a system those, as Africa, as Asia, as Latin America grow in their manufacturing capabilities, that the benefits are there. The benefits for the research institutions that my colleagues are working with in all throughout sub-Saharan Africa in discovery, that the scientific expertise that's there is being developed. So that's a sustainability question. It's not a moral question. What are we going to do? How are we going to make this system work? So from our perspective, DEI, to go back to your question, very specifically, DEI needs to be baked in and is now very much baked in and articulated in the strategy from end to end, from discovery to the last mile, to the caregivers who give it, to the mothers who are either pregnant and need new medicines or who are developing this, providing this for their children. We're going to get better at it. It's not straightforward. The more complex and the more varied our country situations are, the more complex this activity is. But it's the only way to sustain it, and we're quite clear about that.
Thanks, Andrea. I think in respect of time, we'll try and fit in a few questions from the audience, but somebody did tip me off that we were hoping that Madam Matoni, the Principal Secretary of Health from Kenya, was going to try and join us and perhaps at an intervention. I don't see her, but this is WHA, and we all know that the best laid plans can quickly disappear. If not, I'd be very open to other intervention.
Thank you very much. I hope you can hear me. Oh, sorry. Okay, you can now.
That's better. Yes, thank you.
Yeah, so my name is Dr. Sultani Matendechero, Deputy Director General for Health from Kenya. Our Principal Secretary, Mrs. Mary Mudhoni, was not able to join us, but she had a message that she wanted to just pass over to the distinguished attendees here. And so if you can allow me, I'll just quickly go through her message. And she would like to say that Kenya congratulates Medicine for Malaria Venture, is MMV, on their 25th anniversary and appreciates the invitation for us to attend this event so that we can learn, partner in this journey. Indeed, the choice of the theme is befitting at this time when the world is faced with pandemic threats, climate change effects, and an increasing risk of resurgence of communicable diseases and NCDs. Malaria remains a serious public health concern to the world, and especially to children and pregnant women. Whereas we have made strides in malaria control, there still remain challenges in regard to health system weaknesses, inadequate financing, vector versatility, and drug resistance. Kenya therefore welcomes innovative solutions and investment in research and development to end malaria and to welcome no one and to leave no one behind as we develop capacities for pandemic resilience. We applaud the multiple first line program, which is an innovative research sponsored by MMV. With your support, we recently, in partnership with Strathmore University, the Kenyan National Malaria Control Program, and other stakeholders conducted a study on health system challenges associated with the deployment of multiple first-line treatment for uncomplicated malaria. The findings of this study have been a milestone towards addressing health system challenges of human resource and financing to address knowledge gaps and malaria commodity security. Finally, we would therefore like to extend appreciation to the great work that the global partners, most of whom are in this room, the work that they are doing to reinvigorate the fight against malaria for a malaria-free world. Thank you. Signed, Mary Muthoni, Principal Secretary for Health in Kenya. Thank you very much.
Thanks very much for delivering the message, and thanks very much to Madam Muthoni for sending that along. We're getting towards time, but I think we should try and fit in a couple of questions to our excellent panelists. In return, I promise I'll keep my summation down to 30 to 50 slides. And then we can get to the buffet. But please, if anybody's got some direct questions to any of our panelists online or in the room, please wave to me. Obviously, it's clear, and you've heard the quotes popping. Please, down here, and then there's one more up on the left at the back there. Okay.
Happy birthday and anniversary to VVA Medicines for Malaria Ventures. Distinguished colleagues, my name is Dr. Patrick Agurusi. I work for Amref Health Africa. To all the panelists and perhaps colleagues from Medicines for Malaria Ventures, do you have an example of a community, a country, where this question of DI has been answered, that we can learn from, because it's a very important topic, and it's a very big destabilizer of how we can reach voice services. We have anywhere where it's working very well, what they have done, and where we can learn from those lessons so that we can replicate them or start taking them on. Thank you.
Who would like to take that question? Anybody want to wave at me? Andrea?
What I will do in this case is I'll connect you to some of our best access colleagues who are in the room. I know Andre Marie is here. We have some other people to be able to speak about that specifically about some of the areas in those countries in which we can provide the most relevant examples. I would like to make a comment about the need in general for this to be an ongoing piece of activity that we need to continue to share and work on. As we begin to understand what diversity looks like, and we understand what equity looks like, and we understand what inclusion looks like, our need for our understanding of how we work in partnership becomes more complex. And one of several of my colleagues over here, I see that there's actually an MMV, looks like there's an MMV fan group over there, the baseball team there. One of the things that several of our colleagues have brought to our attention, and I think, Philippe, you said something similar, is that one of the most important places this starts is our interrelationship with each other. How are we managing our own ways of interacting with each other, our own ways of thinking with each other, and our own ways of moving forward? And are we making this an ongoing set of activities? I don't think anybody in the world would be able to say, DEI is solved. It's all done, right? Because it's a constant process, A, of learning, B, of getting better, and C, of a really strong set of pushes from the external world to actually not pay attention to this, to say, look, this really isn't a problem. This is a women problem, right? We'll take care of it. So there's a really strong push to not continuously evolve in this direction. And so from an overall perspective, that's one of the ways we need to move forward. In the specificity of countries and activities, I'll make sure that you get connected. And maybe you would like to comment a little bit on this in Women in Global Health. No? Okay, very good. I hope that's useful, and we'll make sure that you have more.
Thanks. Time for one more question, if somebody has a burning question. I have another 25 slides, so if you don't get in, I could bring them out. No. Great. Well, first thing I want to do really is to thank our fantastic panelists, both those online and those in the room, for a really interesting discussion. So before I talk, please join me in giving them some thanks. And just the last word on this. We've heard some great examples, but I don't think you've heard anything that is new to you. And I go back to what Philippe says. The problem is not that people aren't speaking, it's that we are not hearing, we are not listening enough to these stories to find out. Access isn't about just having the right drug. It's having the right drug with the right people at the right time. And there's a whole range of complexity in achieving this. And all too often, engaging the community is seen as a problem or slowing down a process. But in fact, it's the solution, because we will never have true access unless we have the inclusion of the communities that are affected by these diseases and can bring this rich perspective that we've heard some of tonight to this. So thanks again to the panelists. And I think, am I handing back to the chair? And thank you all for your attention, and I hand back to DNDI.
Okay, the chair is here. So I will have just some thanks. Actually, as Professor Reader said to the moderators and speakers for the two panels, I will add also the thanks to our co-hosts. From Ghana, from Switzerland, and also to the people who contributed to the event. And I would like to mention particularly Susan Brown, who the speakers now know very well because she helped a lot in putting together the programs. She's there with the red shirt. And obviously all the colleagues in MMV, the communications, the events, colleagues, but also well beyond, actually a lot of colleagues who helped with identifying the speakers and inviting them and preparing with some ideas for this event. The technicians, of course, that created this very nice environment, interpreters, and so on. And obviously to all the participants, the one who asked questions, but in general that participated in this event, because I think it's a very good indication of the people who are quite committed to this topic, with whom we would like probably to continue to work, and also who are good friends of MMV. I think in this, I think we can move, the formal part of the event has finished, but it can continue in the reception, which is preparing over there. And that's all, I suppose. Have a very nice time at the reception, a very nice evening, and a good continuation of your week at the WHA. Thanks a lot.